Okay, Bismillahirrahmanirrahim. Good evening, everybody, and welcome to a new webinar of the CME courses of the Egyptian Society of Nephrology and Transplantation. And tonight we have a new meeting with kidney transplantation. But let me know in the beginning الحقيقة في البداية أحب أن أقدم خالص التعازي للأخ العزيز أستاذ الدكتور ياسر عبد الحميد في وفاة والده رحمه الله وأسكنه فسيح جناته وألهم أهله وذويه الصبر والسلوان. خالص التعازي للدكتور ياسر. Tonight I'm pleased and honored to introduce my dear brother and friend, Professor Ahmed Halawa, consultant transplant surgeon and associate professor at University of Liverpool in UK. And he is also the program director of the fellowship in clinical transplantation organized by the Arab Society of Nephrology and Kidney Transplantation. Professor Halawa is going to take us in another new tour, interesting tour of a variety of real life case scenarios full of lessons and messages. I hope and I'm sure that you are going to enjoy it. Please, Professor Halawa.
Thank you very much, Professor Ayman, and I pass my sincere condolences to my friend and my brother, Professor Ayman, Professor Yasser Abdul Hamid, for his father's death. Apology, he's not with us today, but hopefully he can make it next week. So today, actually, we discussed a few cases, good things and bad things. So we have to learn from both sides. We are not perfect. We try to do our best, but still we do mistakes. Still we learn from mistakes. We keep learning till the last second of our life. So I am Ahmed Halawa, as previously introduced. I'm a consultant transplant surgeon. I don't call myself surgeon, I call myself clinician because I deal with the medical and surgical aspects of kidney transplantation. Transplantation is a separate subspecialty. And I borrowed this slide from my friend, Professor Ali Saidi, president of Iraqi Society. And actually, it's very informative. Without data, you are just another person with an opinion. Professor Edwards Deeming is an engineer and also a statistician. He has his fingerprints in statistics. So we take his word seriously. So all about data, data, and data. Remember, there is no wrong answer, but there may be a better answer. And this is what we are looking for, a better answer, a better scenario, a better treatment. Of course, you will get better outcome. I would like to remind you about the level of evidence. So medicine now is an evidence-based practice. At the top, systematic review and meta-analysis of RCTs, randomized controlled trials. At the bottom is expert opinion and personal opinions. So just be sure that you talk based on evidence. And if there is no evidence, we can say there is no evidence and this is the best available evidence. But if there is an evidence, we have to stick to the evidence. The first case, a 31-year-old male received a kidney transplant from his brother 7 years ago. 1-1-1 mismatch. No pre-transplant DSA's primary function. We had basiliximab induction, tacrolimus-based triple immunosuppression as maintenance. The serum creatinine increased from 103 to 200 micromole per liter. Both DCA and C4D staining was biopsied. DCA and C4D staining both were negative. And let us see his histology. Have a good look. And we have few questions. Describe the significant feature of this biopsy. Any more tests required to confirm your diagnosis? What's your management plan? Feel free to respond to the questions. Can we see the biopsy again? Okay, I'll do my best. And this is a biopsy. We are not pathologists, but there are striking features in this biopsy. Yes, my friends, come on. Chronic sinoid toxicity, vascularizations, chronic sinoid toxicity, EFTA, HENDA. So what do you see? Yeah, I mean, of course, you're right, sinoid toxicity, but can you explain further? What do you see here on the right-hand side? What do you call it? Joint endothelial cells. This is not right. Yes, well done, Muhammad.
Yes.
Yes, right pattern fibrosis. Yes, this is typical picture of chronic sinoid toxicity, striped interstitial fibrosis. Yes. What about on the right side? What do you think about this? Again, well done. Yes, arterioral hyalinosis. Yes, this is a nodular form of arterioral hyalinosis. Yeah, yeah. Of course, we're not discussing the management because everyone knows the management. But the whole idea is today is just this is a chronic sinoid toxicity, striped interstitial fibrosis, arterioral hyalinosis. Yes. Okay. Shall we move to the next? Case 2.
I think we can answer the other two questions, Professor Ahmed.
Okay. Okay.
You addressed two questions.
Any more tests? Because they talked about it.
Any more tests? Yeah.
Any more tests?
Okay.
That level. Yes.
That level.
Yeah. Yeah.
Okay.
Okay.
What's the management plan?
So management plan.
Okay, this is an
Which
option.
in my level.
Okay. Is there are any more options rather than decreasing the dose of tacrolimus?
This is one option. So the second option is shift to sirolimus. Yes. Okay. I mean, because I don't like,
Great.
Professor Ahmed dragged it to the management plan. Fine. How to shift to sirolimus? What are the criteria should be fulfilled to
Okay.
switch to sirolimus? GFR, yes. Yeah, GFR. What
And
GFR? More than 30. It's actually is more than 40.
yeah,
40 and above. Yeah. What else?
which is more important than
No
looking for the
proteinuria.
proteinuria, yes.
Yeah.
Yeah.
Actually, proteinuria should be less than,
Half gram.
yeah, I mean, 800, whatever. This is based on the
Okay.
symphony trial. Yeah, it's less than 500. Okay. I accept that. Yeah. Okay.
Hmm.
What's the problem? What's the main problem with sirolimus?
Hmm.
Infertility. It does, but this is not the main problem. But, collectively, what do you think about sirolimus? Discontinuation rate, excellent, Hemda. Yes. Dropout rate. Yeah, I mean, this is
Yes.
a toxic drug. I mean, in Sheffield here, unfortunately, we didn't have good experience with sirolimus, and most of the patients who were on sirolimus were switched back to tacrolimus and even to cyclosporin. Yeah, side effects. It's all about side effects. It's very bad side effects: mouth ulcers, hyperlipidemia, proteinuria. Yeah, dyslipidemia. Great. Yeah.
Resistant lower lip edema, pneumonitis.
Yeah. Pneumonitis usually. Oh yeah.
Okay.
So yeah. So the side effects and the dropout rate is high with sirolimus.
Great.
Case 2, a 31 years old male received a kidney transplant from his brother 3 weeks ago. 111 mismatch, no pre-transplant DSA, primary function, had basiliximab induction, tacrolimus-based triple immunosuppression as maintenance. Serum creatinine was stuck to at the level of 200 micromole per liter. He developed a new DSA against B53 with MFI 4,500 post-transplantation. C4D staining was negative by both immunohistochemistry and immunofluorescence. The biopsy shown below, which shows lymphocytic infiltration in the glomeruli and in the peritubular capillaries. So C4D negative, but with GCA. What's your working diagnosis? Nadine, antibody-mediated rejection. Can you be more specific, Nadine? Yes.
C4D.
Mustafa,
Right.
well done. Mustafa from Iraq. Well done, Mustafa. Yeah, C4D negative antibody-mediated rejection. Yes.
Great.
Excellent. C4D negative fluid. Yes, Asma could go. We haven't finished yet. What's your diagnosis? Yeah. What's your management plan? How would you manage it? Few words.
Okay. This is the main core of the management.
IVIG, yeah, IVIG, and the Hassan plasma exchange, rituximab,
Yep.
immunoabsorption. All excellent answer, but usually they will give combination of
Mm.
treatment in antibody-mediated rejection. Is it right?
Yes, of course. We should.
Bortezomib, and I never used it.
Mm.
Nadine, very expensive drug. Eculizumab,
Oh,
this is more expensive. It will cost arms and legs. Very expensive drug, not available.
Yeah.
Methylpred, Samah, yes, and plasma exchange. We'll try with methylpred first while getting the biopsy and see this. Yeah, empirical methylprednisolone. Yes, I agree. But this is not a definitive treatment.
plasma and IVIG. This is the right answer, I think.
Yeah,
Professor Ahmed.
plasma exchange was IVIG. Yes, that's right. Fine. Quick question. What's the dose of IVIG you give with plasma exchange? And what's the difference between this dose and the dose you will give for desensitization? Methylprednisolone, ATG. ATG can be used as well. Plasma exchange, IVIG, and rituximab. Yeah, but this is too much, but it is okay. So what's the difference between the IVIG dose you use with plasma exchange and the IVIG dose you use for desensitization? Yeah, there is a right answer here. Gali Qod, 400 milligram kg dose for 5 doses, well done. So 2 grams per kg. Yes, yeah. That this is desensitization, is it right? Yes, and Nisreen from Iran, 100 milligram per kg after each session. Well done, Nisreen. Yes. Okay. Low dose was plasma exchange. Yes, that's right. Yeah. So the difference in doses, 100 to 150 milligram per kg after each session of plasmapheresis. Usually we give 4 to 5 sessions. And this dose is different from the dose recommended in desensitization, which is 2 grams per kg. Either you give it on divided doses or 1 dose, but it should not exceed 140 grams total. Fine. These are the easy questions, but I'm trapping you with this question. Which technique is more sensitive in staining C4D? Immunofluorescence or immunohistochemistry? And قال قد immunohistochemistry. No?
Mm.
Immunofluorescence, of course, is more sensitive and more specific. But the problem of immunofluorescence, it stains normal glomeruli. So you get positive control. This is why we do both together. We do the immunohistochemistry, and this is our practice in Sheffield. Immunohistochemistry, because immunohistochemistry, that if the glomeruli are normal, won't get stained. And immunofluorescence for the interstitium. Fine. Do you think C4D negative antibody-mediated rejection is associated with better prognosis compared to no antibody-mediated rejection? I'm giving you the answer here. Just read it.
Yes.
C4D negative MR, usually a chronic form, usually delayed. It's associated with worse prognosis. Still, prognosis is bad. It does not involve complement. And this is why we don't have C4D. And usually the graft fails late. Commonly is class 2 DSA causing C4D negative MR. And you can read the mechanisms here. I have written it for you. No difference. Fine. Move on. Third case, a 66-year-old CKD5 received a kidney transplant from his wife, 202 mismatch on tacrolimus-based triple immunosuppression. His serum creatinine went down to 121. Start to go up during the same hospital admission to 231 micromole per liter. His blood picture showed anemia, thrombocytopenia. His liver function test showed raised bilirubin. Urgent blood film and kidney biopsy are shown below. Diagnosis is
Great.
TMA. What can you see on the right-hand side of the slide here? And what do you see on this side? TMA, yes, Mustafa, well done. Sister right, excellent. Yeah. We have excellent colleagues here. Mahmoud Islam, well done. Mahdi, TMA. Microthrombi, Muhammad Chat, yes. Microthrombi, thrombosis actually here in the very clear. What's your diagnosis? What's your management plan? What's your diagnosis? I think Professor Ayman has a comment here. He's good to trapeo, plasma exchange, back level, and DSA. Yeah, excellent. You know, Rami Abu Bakr, yes, DSA. Why Rami DSA? Are you expecting something?
الكيمياء كان used by antibody mediated rejection.
Yeah, antibody mediated rejection. Well done, Rami.
Yes.
Yeah. Usually, TMA is associated with severe form, severe form of antibody-mediated rejection. There is some pictures of TMA in the glomeruli as well. Yeah. How do you confirm it? Yeah, C4D staining. Yes, Mustafa, well done. What else you need to do? Electron microscopy, yes. What else? Something simple. DSA.
Yeah. Yes.
Yeah, I think one of the colleagues mentioned DSA early on. Yeah. So this is bad sign. That level, yes. Fine. So if you excluded antibody-mediated rejection, so no tissue injury, no lymphocytic infiltration in the peritubular capillaries, DSA not raised, and C4D staining was negative. And this patient on tacrolimus, what would you do? And develop this picture. Stop plasmapheresis. Change, Ahmed Abdullah.
Change to what?
Yeah. Is on tacrolimus. Sirolimus. Change to cyclosporin, also sirolimus. Yeah.
What do you mean by conservative?
There's conservative here?
Yes. Someone write conservative.
Okay. What do you mean by conservative, my colleague? Your remix sentence. Stop tac. Yeah, stop tacrolimus, yes, but you have to give him something else.
Yes. So I think we have two options here, Professor Ahmed.
Yeah.
Either to change to the other CNI. However, some may argue that they have the same mechanism in inducing the TMA, and the other option is to shift to mTOR inhibitors.
Yeah.
Although they are also could
Associated
induce
with,
TMA. Yeah.
Yeah. So unfortunately, many immunosuppression medications, can cause TMA. So basically, we switch to another immunosuppression and pray that it won't happen again.
Yeah.
Yeah, but that's accept if available. But you switch to cyclosporin and soromas. They are available. Colleagues, friends, please, reflect on your practice. Do you have Blatacept? If you don't have it, you can't use it. ATG and whole CNI. I won't give ATG. I will switch.
Yes.
Rami, it's too much. You're killing a fly with a cannonball.
Yes, and for how long we are going to give the ETGs? ETG is just a bridge in cases when CNI could not be given.
ETG if there is antibody-mediated rejection suspected.
Oh, okay.
And actually, I agree. I treated one case like this but the diagnosis was inconclusive. It was three potential diagnoses, which is not unusual, from pathologists. Picture of TMA, picture of CNI toxicity. However, antibody-mediated rejection could not be excluded. And this is a candidate for ETG, of course, to stop everything and give him strong immune suppression. Yeah, fine. Let's move on. Yeah, TMA, think of antibody-mediated rejection. You need C for destaining, DSC, and look for evidence of tissue injury. Case 4, this patient received a renal transplant 5 years ago with an excellent function, with a stable serum creatinine around 135 micromole per liter. He's currently on cyclosporin-based immunosuppression, calcium channel blocker for his hypertension, statins for his high cholesterol, and phenytoin for his epilepsy. It is not uncommon in our transplant population. He complains of painful bleeding gum, especially when he brushes his teeth. His gum looks as below. I've seen it. Fine. Let's back to the question. Gingival hyperplasia, nausea, phenytoin, induced cyclosporin toxicity, gingival. Yes, we agree on gingival hyperplasia. How would you manage? Nawaf, yes. Effective phenytoin. What else can cause gingival hyperplasia in this scenario? Cyclosporin, yes. We agreed on the anti-epileptic. Yes, calcium
channel blocker. Okay.
Well done, Henda. Yes. All the 3 drugs.
Yes.
Right there. So we need to change everything. Okay. You're very unlucky. Is it right?
Yes.
Fine. What's causing? How would you manage? So we need to change the 3 medications. So the calcium channel blocker. We need to change the cyclosporin to tacrolimus we need to change that phenytoin to an anti-epileptic.
Although this was a very straightforward and easy case, Professor Ahmed, but we can see it in every hour day practice. So we should shed light, although it's common, and we have to, I mean, to keep it all in mind, the drug interactions with the cyclosporin, and because some may, I mean, focus on the immunosuppression, on shifting the tacrolimus, cyclosporin to tacrolimus, and forget about the other drugs.
Yeah.
So I think we should keep in mind especially the nifedipine of the calcium channel blocker. Not all calcium channel blocker can cause gum hyperplasia. It's the nifedipine, and also, of course, the phenytoins.
This is true. This is true. Well, we used to send them to the dentist as well for gum treatment, and switch the medications. To be honest, in many occasions, you see the patient for transplantation already on calcium channel blocker, and he has gingival hyperplasia. So this is why he needs treatment prior to transplantation, because if he becomes, if it's tacrolimus intolerant, when we have to switch to cyclosporin, you avoid the gingival hyperplasia. Fine. The case 5. A 53 years old CKD5 female patient on the waiting list for 7 years. She received a kidney from a 34 years old DBD donor, cadaveric donor, 1-1 mismatch with excellent kidney function. She has DSA, basically HLA DQ with MFI 1700. Cross match, flow cytometric cross match was negative, both B and T cells. Will you accept this kidney? If yes, how would you manage this transplantation? If yes, what's the long-term survival of this kidney? If no, what's the alternative? Yes, yes, accept. Mustafa. Kora. What do you mean by Kora, Mustafa? Yes, yes. Basically, posture integration conveys and full of this. Who is this genius, Henda? Yes. Henda Hassan from Sudan.
5 below 3,000.
Yeah. Mustafa Gamal, yes. Below 3,000, yes. Paired exchange.
Yes.
This is a cadaveric donor. It's not a living. Yes. If it's living, I would think of paired exchange. Ahmed Arif, due to the long waiting time, I will accept the offer. However, I will recommend potent induction with T-cell depleting agent, and there will be transplant DSA. Tag-based, really, ETG induction, fine. I agree with most of the answers, but what we did is transplanting this patient with basiliximab induction.
You are so brave, Dr.
No, because number one, you have to think of the DSA specificity. This is class 2 DQ. I wouldn't worry much about MFI 1700. If it is 5,000 or more, this is definitely worries me. Number one. Number two, there's specificity of DQ and DP, which is the expression. They might not be well expressed on the kidney. So again, with this considered low level MFI, we can get away with induction, basiliximab induction. We transplanted this patient with basiliximab induction. Went very well, no rejection.
Okay.
If no, what's the alternative? It was a trap because
Yes.
there's no alternative to transplant this kidney.
Yeah.
He'd been waiting on the waiting list for 7 years. So this is the best offer. It's like a lottery. He won the lottery. So he wouldn't think about it. No, just if he agrees, give it to him. Case number 6, a 31-year-old man presented with sudden excruciating headache and seizures. The headache is more severe in the morning, few hours after taking his medications. He had undergone his second kidney transplant. This was a second kidney transplant. He received triple immunosuppression. His serum creatinine is 189 micromole per liter. Because of this picture, we MRI his brain and read the report carefully with me. This is actually a summary of the report. Multiple areas of low signal intensity in the pons, medulla oblongata, basal ganglia, and also in the cerebral hemispheres. Lumbar puncture was entirely normal to exclude infection. Tacrolimus level was 8 nanogram per ml, within the acceptable range.
Press, yes.
And this is actually the picture of his MRI scan.
Okay.
Let me get back to the report again. Pons, medulla oblongata, basal ganglia, and also cerebral hemispheres. What is your likely diagnosis? What's your management plan? What are the other conditions that can cause a similar picture? Yeah, omnia, press syndrome,
Hypercalcemia.
hyperkalemia, Ahmed Abdullah.
Calcemia.
Calcemia? Calcemia, yes. Press. Fine, but press is posterior reversal encephalopathy syndrome. Is it right? By the way, press was 1 S, not 2 S. So it's posterior reversible. This is not posterior. You still agree with press as a diagnosis?
Toxic metabolic.
Cerebral lymphoma, Shawty basal ganglia infunction, complications, neurotoxicity due to TAC. I mean, yeah, TAC is neurotoxic, I agree, but level is 8. Could be. Toxic, this is differential diagnosis, toxic metabolic encephalopathy. Mina, yeah, this is ambitious. Nadine, mainstream, PTLD, mucoencephalopathy syndrome.
Lymphoma.
Diagnosis, yes, okay, could be differential diagnosis. I agree with you, Mina. CNS lymphoma.
Email.
Okay. You want to get surprised? Vasculitis. This is press. This is a typical picture of press, which is basically posterior, but if you read my comment here, it's not always posterior and not always reversible as well. So this is a typical picture, and I Googled press for you. You can have different pictures of press as well. So here, frontal lobe involvement of the temporal lobes, thalamus, brainstem. So if it's not posterior, it doesn't mean it's not press. Yeah. So still press. How would you manage?
Why to change that? Okay.
Change scenario, change scenario,
Okay.
change scenario. Yes, yeah.
What do you mean by conservative? Choose blood pressure. Control pressure.
Shift go into, yes.
Yeah.
You change the C9 to another C die or change to M2. Yes. Yeah, this is the right answer. Remember, not always posterior, not always reversible. Case number 7. Polymorphonuclear leukocytes are rarely seen in interstitial infiltrate following kidney transplantation. The presence indicates a serious event. Will you elaborate more on the above statement? So what are the significance? What is the significance of polymorphonuclear leukocytes in the biopsy? What does it indicate?
Pyelonephritis, right?
Okay. What pyelonephritis? Rejection. What kind of rejection? Interstitial nephritis nasec, pyelonephritis galli, interstitial nephritis, rejection. What kind of rejection? Yes, antibody-mediated rejection. Well done, Mina. Yeah, but in to diagnose antibody-mediated rejection, you need to find them in the blood tubulitis. Tubulitis was lymphocytes, not polymorphonuclear leukocytes. Peritubular capillaries. Yes. You need to see them in the peritubular capillaries. So pyelonephritis, yes. Bad rejection. What else? Another differential diagnosis missing. They might be found in TMA, the thrombus of TMA. And in reality, this is a case who had empirical antibiotic before coming to the transplant, drainage kidney function, urine culture was negative, biopsy, we found this. And Professor Ayman has similar experience with this. Will you tell us about it, Dr. Ayman?
Yes, we are confronted with many cases with sterile pyuria or even no pyuria, and we astonished by the presence of typical pyelonephritis in the graft, even presence of infected casts in the tubules.
Yeah.
So we diagnosed many cases by biopsy.
Yeah. So it's surprising that pyelonephritis has been diagnosed by biopsy. Yeah, it happens. Yeah. It happens with us. It happens in Mansour as well. So just be aware that we could be missing infection because of the empirical treatment.
Yes. Because simply if we found I mean frank urinary tract infection, we would not go for the biopsy.
Absolutely.
So yeah.
Okay. Key point, transplant burial nephritis, especially after empirical treatment. So yeah, MR, especially if peritubal capillaries are involved, it may be seen in TMA. The eighth case number 8, a 42 years old male transplant recipient who received a kidney with 1-1-1 mismatch from a deceased donor, cadaveric donor 4 years ago. Currently, he is on dual immunosuppression, sirolimus. This is one of the few cases kept on sirolimus, but you will see what happens later. And prednisolone, 5 milligram. He's complaining of right shoulder pain requiring regular analgesia. His recent serum creatinine 132 with no proteinuria. So shoulder pain, transplanted 7 years ago.
A vascular necrosis, right? That's.
So what do you think? A vascular necrosis? A vascular necrosis? A vascular necrosis? Fine. My question is, would you diagnose a vascular necrosis in the shoulder by plain X-ray? Need MRI to be confirmed, MRI. But does a vascular necrosis affect the shoulder? Yeah, Mohammed, yes, there's a good answer here. Really. Yeah.
The hip, right?
Yeah, osteonecrosis. We have excellent, mostly hip, yes, mostly hip, but can affect any joint. And please don't rely on plain X-ray.
Yes.
So what do you call this condition? A vascular necrosis of the right shoulder. How often affects the shoulder joint? Rare, but it does happen. Affects many joints. The knee, the shoulder, temporomandibular joint. There are, what are the predisposing factors? I've seen an excellent answer here. Just sirolimus, but this patient on steroid as well. So the cumulative dose of steroid. Yeah, sirolimus. How would you manage? Number one, MRI scan to confirm the diagnosis. And even if the plain X-ray is negative, I will still do an MRI scan. If you didn't do it, the orthopedic surgeon will do it for you. What's your management? Surgical, mild cases, corporate compression, keep steroid replacement. But yes, keep steroids. Why you keep steroid? Why not stop steroids? Bone graft. All are good answers, but we are not qualified to treat a vascular necrosis. So basically, we need to stop sirolimus because we have tissue damage here to allow healing, and refer to orthopedic surgeon. Yeah, I think this is enough for this case. Yeah.
I have a comment here, Professor Ahmed.
Yeah.
Uh, regarding sirolimus, sirolimus is one of the risk factors for development of what's called premature osteonecrosis or avascular necrosis. I mean, within the first year. This is the feature in sirolimus. For steroids, as you mentioned, it needs a cumulative dose on for a long time to induce the ischemia and the microthrombi and of the avascular necrosis. But the reports about sirolimus that it goes within the first year post-transplant. So I think sirolimus should be kept in mind as a new or a common risk factor for osteonecrosis, beside, of course, the cyclosporin and the steroids, etc.
Yeah, and the most important thing is to allow healing because this patient will have an operation. So to stop sirolimus, switch to
Yes,
another.
but if he have the core decompression is simple. The drilling procedure is simple. It takes about something like 15 minutes without I mean
Illustration.
a
But
large wound.
still I switch.
Yeah,
I
and
will still
early
switch
stage. But
sirolimus.
for of course, yeah,
Mm.
yeah.
Because you
But
know,
of course, for the hip replacement, we need to stop sirolimus for the healing. Of course, this is a major surgery.
okay. Fine, let's move on. A 57 years old lady on transplant waiting list for 11 years. Her primary disease, other polycystic kidney. A family friend came forward for donation. The mismatch is 010. Fax cross match, flow cytometric cross match is positive for both B and T cells. Auto cross match is negative. No DSA detected on many occasions. How do you explain this cross match? What's causing it? What's causing positive cross match? Would you go ahead and transplant her?
And the right answer.
If you decided, if you said to go ahead, what's your immune suppression protocol? Yes, أمنية non-HLA, نسرين non-HLA, مصطفى جمال non-HLA, 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 رامي antibodies non-HLA, non-HLA.
Okay.
Excellent. This is a typical picture of
Non-HLA.
non-HLA antibodies causing positive cross-match. No need to desensitize. What would you do then, Rami? How would you transplant her? HEG tag-based triple immunosuppression? HENDA? You're very good HENDA. Unless you are a mind reader. Yeah, HEG with triple immunosuppression. Yes. Yes. I'm waiting for more answers. HEG with triple. Yeah. HEG. Okay. Ahmed Arif. Yeah. Okay. Fine. Yes. Actually, this is what happened. I couldn't understand why a family friend knows her for years and years came to offer her a kidney after 11 years. But anyway, this is family issues. I'm not interfering with it. Definitely, yeah. We transplanted her with HEG induction. I agree. This is, you know, we don't need to desensitize these patients because you don't know what type of non-HLA antibody is causing it. And the level as well. You need to know the offending DSA or the offending non-HLA and the level before you do desensitization. So typical picture of non-HLA antibodies. Would you transplant this case? Would you desensitize? No. And this is what we did. ATG induction, transplanted, kidney failed 4 years later. And actually, the patient died a month after landing on dialysis. But you can see this is a typical effect of non-HLA antibodies. Gradual deterioration of kidney function. She had a biopsy. And the biopsy, as usual, was inconclusive. Said, picture of endothelialitis. Couldn't understand, but the creatine G4 at that time was 11 and landed on dialysis. Died of ischemic heart disease. Fine. Case number 10, a 36-year-old renal transplant recipient presented with rise in serum creatinine 2 weeks after the operation. He received triple immunosuppression tacrolimus-based Doppler scan demonstrated 3/2/7 sonal lucent collection near the upper pole of the kidney. No evidence of renal arteriostenosis or hydronephrosis. Tacrolimus level reported to be 16 nanogram per ml. What would you do?
Abscess.
Urinoma, seroma, abscess. This is the differential diagnosis. Hematoma, Ahmed Abdullah urinoma,
Mustafa Gamal. Excellent.
CT scan, lymphocyl, MENA aspirate, cytological and chemical analysis. Yeah, it could be lymphocyl, it could be serous fluid. It could just seroma. So aspiration, Sabah, Aman Anan, CT. Full up size with size, full up with the size. Hinda Hassan, aspiration, CT scan, Nazik aspiration, drain analysis, Ahmad Hisham aspiration analysis if applicable, aspiration ultrasound guided analysis. The tacrolimus level is high. Akram, well done, Akram.
He's trapped.
Yes.
Akram is trapped.
Well done. Yes. Just follow up. Gali code. Yes. Actually, I will do nothing.
Yes.
I will just what Akram said, Akram Siaji, just tacrolimus level was high, so reduce tacrolimus. This is a collection upper pole of the kidney. It's away from the hilum, away from the ureter, with no pressure symptoms. Why to stick a needle and drain it when why to introduce infection? It's not in a dangerous place. Yeah. If it's close to the hilum, I would think twice, could be compressing the renal pelvis or compressing the vein. If it's near the ureter, could be obstructing the ureter, but it is not. It is a small collection and no signs of infection. I will leave it. I wouldn't do even CT scan.
Yes.
Just treat the high tacrolimus level by reducing tacrolimus.
I think the only active interference is just maybe follow up with ultrasound.
Yeah, I mean,
Yeah.
every now and then.
This is the every now and then.
Yeah,
No more.
conservative, yes, conservative. Yeah, aspiration. I disagree with aspiration. You aspirate when it's needed, when it's indicated. It's not indicated. Upper
Yes.
pool of the kidney, away from important structure in the hilum here, away from the ureter. It's not compressing the bladder. It's not infected. It's a clear fluid. Even I don't want to know whether it's lymphocyte or serous fluid.
Great.
Do nothing except treat the high tech level. So the size or whether infection or not, pressure symptoms, the location are important. Fine. Okay. Case number 11, a 47-year-old renal transplant recipient presented 2 weeks after transplantation with deterioration of kidney function, fever, 38 degrees, leukocytosis, and raised CRP, 78. The normal is up to 5. Ultrasound showed 9 by 10 by 9 centimeter complex collection with internal echo pattern. What does it mean? There's mild hydronephrosis, which has not changed from the previous scan. CT scan is also shown. And actually, this CT scan was a month later. Let's go back to this first. So we need the magic answers. Infected urinoma. Why Radwa urinoma? Abscess, yes, I think this is abscess aspirate. Abscess, infected urinoma. Drainage, abscess. Yes, Amal. Yeah, antibiotic. Infected collection should be drained. Yes.
Right answer.
Yeah, right answer. This is an infected collection. Yeah, and it should be drained and treated with antibiotic as well, according to cultural sensitivity. I mean, this is a very sad story, but we'll discuss this story later on. And this is a month later. What do you think about this? It is still infected.
Mm.
Yes. Fine. A month later, this is a thick wall. So this is evidence of chronicity here. And if you notice, there is air here. So it's still infected. So radiological drainage, basically ultrasound guided drainage, it didn't work. And the operation was, you have to drain it surgically. Will you do laparoscopic fenestration? Drain it into the peritoneal cavity. Ask the surgeon to do it. Will you do this? Exploration.
No. Yes.
Yes.
Okay. Yes.
It indicates hematoma. Yeah. I
And
agree with you.
no. Yes.
Why? Laparoscopic work is minimally invasive and you can drain it into the peritoneal cavity.
Ahmed عارف not for infected material, right?
Yeah, not infected. Yes, absolutely. This should be surgical by surgical intervention and exploration of the collection. Because if you drain it into the peritoneal cavity, you drain infected, you drain basically pass into peritoneal cavity. You spread the infection and you change the whole picture from localized infection to peritonitis. Yes, peritonitis, galley. Agree. Air producing organism. Whatever it is, it's a producing organism, but there are signs of chronicity here.
Thick wall.
Mm.
Yes.
Yeah, we agreed on the management. So signs of the infections are signs and symptoms: fever, leukocytosis, internal echo pattern or ultrasound scan suggestive of infection, thick wall, air. Yeah, next. A color Doppler ultrasound from a patient with a graft tenderness and absent urine output in the early postoperative period is shown below. Significantly reduced flow is noted within the kidney, with only one definite arterial vessel seen in the upper pole. The venous flow was absent throughout the kidney and in the main throughout the kidney and in the main transplant vein. Spectral Doppler sample from the internal interrenal artery showed the reverse diastolic flow. So basically, the conclusion here: diminished perfusion, venous flow is absent, there's some arterial flow, and there is reverse diastolic flow on Doppler. These arrows indicate reverse diastolic flow. So what's your diagnosis? And what would you do? Radwa, renal vein thrombosis, renal vein thrombosis, Gali antibody-mediated rejection. Renal vein thrombosis, exploration, MRA, yeah, renal vein thrombosis, MRV, surgical nephrectomy. Yeah. Yes, this is a picture, classic picture of renal vein thrombosis. Absent renal vein on Doppler scan, diminished flow in the kidney. It could be some arterial flow and reverse diastolic flow. Few questions here. Where do you check for the reverse diastolic flow? In the artery or the vein? Oral anticoagulation? In the artery? In the artery. Ahmed Abdullah, yes. And yes, in the artery. Mina, in the artery, yes. I totally agree. Yes, you check in the artery. Fine. Will you take him to theater? Will you do any fancy intervention? What will you do something else to confirm your diagnosis? Akram change not in the vein, Akram, vein thrombosed. Reverse diastolic flow is almost always in the artery, because the artery, the systolic flow is facing massive resistance. What would you do next? CT angiogram, yes, Nazik. MRV. CT scan, DTPA scan. Yeah, okay. Yes. Actually, yeah, we, our protocol in Sheffield is once you diagnose something like this, based on ultrasound scan or Doppler scan, the patient will go for CT, contrast CT. Meanwhile, theater is booked. MRV will take a while to arrange it. CT is easier. So we'll put them through the CT scanner. We never succeeded to salvage any one of these kidneys. But Professor Ayman has good experience with salvaging kidneys like this. Is that right, Ayman? No? If it is early,
Yeah, if it's early, Professor Ahmed, we can we have some experience and salvage such kidney by, but actually it was not complete occlusion of the vein, and it was early, and we went for the contralateral femoral vein and catheterize it, and reaching the graft vein and inject thrombolytic therapy. And the kidney was salvaged by our expert radiologist, Professor Tarek Diassi. Actually, he did it several times. So it needs to be very early diagnosed and not complete occlusion. So this is the key of success of such intervention. Otherwise, the condition will end by a nephrectomy, as you said.
So the key message here, when you get a Doppler scan, you don't rely on Dopplex, because in many occasions, Doppler scan didn't show good perfusion of the vein, or the vein is not visualized, the reverse of the diastolic flow, and you CT scan, kidney still perfused. And there is venous flow. Differential diagnosis of reverse diastolic flow could be just ATN. Yeah. So don't take this patient to theater straight away without confirming the diagnosis. Ultrasound scan is not 100% sensitive compared to contrast CT scan or MRV. But our access to CT scan is quicker. Number 13, a 37 years old, CKD5 patient received a deceased donor transplant 2 days ago. This patient stayed on dialysis dependent. His potassium is 7.1. He still passes urine 1 liter. His serum creatinine has not improved since his transplant, so he got native kidney function. Doppler scan showed resistive index between 0.4 and 0.5. Peak systolic flow is 15 centimeters per second. The flow in the external iliac artery is 315 centimeters per second. There's attenuated perfusion of the kidney and poor perfused cortex, poorly perfused cortex. So the conclusion here is still passing some urine, resistive index low, the flow in the renal artery is low, 15 centimeters compared to the external iliac artery. Usually we compare the flow in the renal artery with the nearby external iliac artery is a good marker of comparison. This is a Doppler scan. What do you think is happening? Renal artery stenosis, Baha, Muhammad Shahat, renal artery stenosis, DGF due to hypoperfusion, Nazik. Just look at the resistive index, Nazik. Nisreen, renal artery stenosis, Akram, ATN. Why ATN Akram? ATN usually associated with high resistive index. Rejection, Radwa. Again, yeah, it could be rejection. Yeah, but rejection
high resistive index also.
Yeah, the rejection does not cause low resistive index, usually high.
Yeah.
Atheroembolic, Bassam. Fine. This wave
Thrombosis.
pattern is called what? An experienced surgeon. Look, my friend, it happens with everybody. And I will tell you why. Excellent, Mustafa. Yes.
Barvastar.
Yeah, excellent. Mustafa from Iraq. Yeah, excellent. Yes. This is a picture of renal artery stenosis or kinking of the renal artery. Tardus parvus refers to the pattern of double ultrasound scan spectral formed due to arterial stenosis kinking. What you need to do, transplanted 2 days ago.
Revision.
Yes, revision. Yes, absolutely.
Yeah.
Take patient back to theater. All the surgeon. Now, this case, yeah, was kink of the renal artery. It was a right kidney transplanted into right side. Right kidney, cadaveric kidney. Usually, as it comes with the long renal artery. It kinked. Yeah, case 14. 61 years old CKD5 patient received a deceased donor transplant 2 days ago. This patient still dialysis dependent, anuric. The serum creatinine has not improved since the transplant. Doppler scan shown below, resistive index 0.9 to 1 with diminished perfusion throughout the kidney. Venous flow was detected. High resistive index. Still dialysis dependent, not passing urine. What's your diagnosis? Venous flow was detected. ATN, Radwa, Mustafa, DGF, excellent. Radwa, yes. Maybe what, Mina? ATN, Rami, of course, ATN, ATN, ATN. Nausea, rejection, 2 days after transplant. Do biopsy, Mustafa Gamal. This is typical picture, ATN or acute rejection. This is a typical picture of ATN. You do biopsy, when do you do biopsy? Wait for, usually we do day 7, day 14. If the kidney didn't open up, we'll biopsy the kidney. So, but this is a typical picture of ATN with high resistive index. But venous flow is shown. Case number 15. A 46 years old renal transplant recipient who dropped his hemoglobin by 4 grams immediately following renal transplant. His BMI is 41. He passes blood stain urine. His vital signs have not changed. Ultrasound scan shown below and reported normal. What would you do? What's wrong here? Hematoma. Ultrasound scan is normal. Sanin. Late diagnosis of collection. Mustafa, retroperitoneal hemorrhage, CT scan. Hematoma. Radwa. CT, urgent CT. Ahmed Abdullah, hematoma. Hemodilution. Bleeding needs CT scan. I would like just to remind you that vital signs have not changed. What do you think is bleeding? Daria Ali, CT scan, Ahmed Arif, CT scan was contrast urgently. Repeat hemoglobin. Repeat hemoglobin came back the same. Yeah, it is a good practice. Hemolysis. Fine. Yes, CT scan. This is actually one slice. Hematoma, big hematoma. And actually, this guy has a massive retroperitoneal bleed. Based on this case, we change our practice. Suspected bleeding, we'll go for non-contrast CT scan straight away. Even if you swear to God that this is hemodilution, because usually this patient will have 7-8 liters in theater. They keep pumping fluid into them in theater. But non-contrast CT scan, suspected bleeding, same sitting, contrast CT scan. We don't rely anymore on ultrasound scan to diagnose bleeding. CT scan. Vital signs. Don't forget this patient will get inotropes, IV fluid. They are on beta blockers. There are many things. So the vital signs usually late, actually with late changes. The classic picture of hemorrhage, which is tachycardia, the grades of shock, classic picture of tachycardia, hypotension, they don't exist in renal transplant patients, even post-operative one, unless it's late. So please, yes, suspected bleeding, CT scan. This is just to test you. Describe the waveform shown below. What do you think about this waveform? What do you call it? Usually late. Yes, Ahmed Arif, well done, Ahmed. And Hassan Uzi, yeah, is bleeding. Yes, yeah. So scenario 16, what do you think here? Monophasic wave. What do you call it? Mustaba. What do you call it? Yes. Well done, Mustafa, because he's the one who answered this question before. Parvus Targus. Yes. Just to test you, this is a picture, ultrasound scan of picture of renal artery stenosis kinking. Case 17. What's the role of bilateral nephrectomy in the pre-transplant workup with special reference to the image below? He reported one episode of UTI, which was treated successfully, and one episode of left loin pain, which resolved spontaneously. And this is the CT scan. Will you do bilateral nephrectomy on him? Mustafa Gamal, yes. Akram, yeah, Mina, yes. As other polycystic kidney disease, yes. Omnia, yes. Dalia Ali, yes. Who says no? Right nephrectomy, Nawaf. Gali, no. Mina, to avoid repeat infection, maybe after the graft. Gali, right kidney only. And the Hassan, no, no space for the new kidney. Large polycystic kidney with infection, other complication better removed. Polycystic kidney not indicated, except pressure symptoms and recurrence, intractable hematuria. Yeah, yeah, okay. Professor Ayman, what do you think? No space, seven.
I think doing nephrectomy prior to transplantation in polycystic kidney need some could be done under certain conditions. Number one, the size, the huge size. I mean by huge size that it's crossing the iliac crest.
Yeah,
So we should have a room for the transplanted kidney.
yeah.
The other thing is the presence of complicated cysts, either by hemorrhage or infection.
Mm,
This is another indication.
mm.
But otherwise, if the size is not huge and cysts are not complicating, so I would leave them.
Absolutely, I agree with you. There's no indication for nephrectomy in this case. This is your conclusion, and I
Yes.
totally agree for the following reasons. If you look at the history, just one history episode of UTI, even without polycystic kidneys, I had put UTIs before.
Mhm.
Loin pain. Who works in the National Health Service without back pain and loin pain? So these are entirely non-specific symptoms. And in terms of space, our marker is iliac crest. I know most of you are nephrologists, but if the kidney extends below the iliac crest, this is where we do nephrectomy. So there is a space, both sides, and the symptoms are not bad enough to subject this patient to nephrectomy. Okay, so it's not indicated here for the aforementioned reasons. Case 18, what's the role bilateral nephrectomy in the pre-transplant workup with special reference to the image below? He reported one episode of hematuria, which resolved spontaneously.
Oh, huge.
There is a space, previous one, there is a space because our marker is the iliac crest, below the iliac crest, crossing the iliac crest. Yes. Yes. Nephrectomy. Mustafa, well done. Radwa, crossing iliac crest. Yes, well done. Ahmad Arif, below the iliac crest. Yes. Yes. Akram, bilateral nephrectomy. Fine. Will you do bilateral nephrectomy or unilateral nephrectomy? Of course, you won't do it, but you ask the surgeon. Bilateral nephrectomy, Akram. Gali, right nephrectomy. Ahmed Abdullah, bilateral. Saja, unilateral. Why unilateral, not bilateral?
Very good question. Yes.
Bilateral nephrectomy due to hematuria also beside space.
Current time of operation, we remove the other
Right,
adaptation.
one time, bilateral one transplant, another
We
space.
cannot remove it at the time of operation. I think, Professor Ahmed, technically the incision is different. I think we cannot remove a polycystic kidney from the transplant incision.
No,
Am I
not with
right?
a small incision, yes, but you make a massive incision to remove.
Massive incision. Yeah, yeah,
And the operation, instead of 2.5 hours operation, it will be 9 hours
yeah,
operation. And you maximize the complications as well,
yeah,
according to the side
yeah.
transplant. Guys, fine.
Should be
What?
staged.
Yeah, absolutely. What's the problem of anephric patients? When you render this patient surgically anephric, what will happen to his blood
Mm,
pressure?
yes.
What will happen to his fluid
Anemia.
balance? What will happen to his hemoglobin? Anemia, yes. What else?
Mm,
Associated with risk of bleeding, of course.
mm-hmm.
Yes.
Residual bleeding.
No residual function, so it will
Mm-hmm.
be sensitive to fluid overload.
Mm-hmm.
Yeah, bleeding. Of course, you double the surgical intervention, so you double the complication rate.
Mm.
What about his blood pressure? He will be shocked due
Yes.
to loss. It's not shocked. We call it postural
I, hypo.
hypotension
Yeah.
because of loss of angiotensin system. But this is transient. Yes. It's difficult to manage these patients surgically in the post-operative period because they become profoundly anemic, they are sensitive to fluid overload, and have hypotension. So when this is bilateral nephrectomy, this is why we prefer unilateral nephrectomy. If he has a problem with the other kidney, after transplantation, we'll go in and remove it. But before we do that, because he has a hematuria, we need to exclude bladder pathology. Ask a urologist do cystoscopy for any patient with hematuria. Because you could be treating polycystic kidney and you're leaving bladder cancer sitting there, hypovolemic shock.
And the other benefit of the cystoscopy that we could see the efflux of blood coming from which
Yeah,
ureter
if
and
you're
from which
lucky.
kidney.
Yeah, if
Yeah,
you're lucky.
yeah.
But yeah,
Sometimes,
if
if we
you're
do
lucky.
it at the time of hematuria.
Oh, yeah, if you're lucky. Fine. My question is, polycystic kidney, is it precancerous? Yes, 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 yes. No. Ahmed Abdullah, yes. No. Mohammed Shahid, no, no. Yes, it's not precancerous. Yes. Yeah? No. No, Mustafa is not precancerous. This is completely different from acquired cystic kidney disease, which is precancerous. Move on. Case 19. Are you okay to carry on or just tired?
I hope they are enjoying.
Carry on, okay. Okay. We'll finish. A 39 years old CKD5 secondary to focal segmental glomerulosclerosis, not yet on dialysis, GFR 16 mils per minute, was referred to you to consider him for kidney transplantation. He has proteinuria 7 grams per day. The serum albumin is 16 grams per liter. Native kidney biopsy is shown below. I'm asking you just to focus on the scenario. So we have here GFR 16, not yet on dialysis. He came to see you to be considered for kidney transplantation. He has proteinuria, of course, because of focal segmental, 7 grams per day. His serum albumin is 16 grams per liter. Native kidney biopsy is shown below. What do you think about this biopsy? What kind of FSGS you have here? And how to prepare him for kidney transplantation?
Depletion.
Need EM? Okay. Tip lesion? No.
Mm.
Not otherwise specified? No. Perihilar? No. Sorry, hilar? No. Collapsing, yes.
Yes. Abdullah Nagar. Muhammad
Collapsing.
Shahat.
Yeah,
Okay.
yeah. Fine. Forget about the pathology. How to prepare this guy for transplantation? He's desperate to have a kidney. What would you do? Start cyclosporin, plasma exchange, screen for the family. Okay, focus on the potential kidney transplant recipient.
Nephrectomy. Muhammad
Nephrectomy.
Shahat. Right.
Yeah. Genetic studies, okay.
Mhm. Mhm.
Still there is activity. He's high risk of relapse, of course, heavy proteinuria, do HIV, Rami high risk, relapse, progressive course. Wait until becomes anuric. You want to wait till he becomes anuric. Maybe after COVID. To screen high risk of thrombosis, relapse,
Mm.
thrombosis. Excellent. Could be lupus. I don't know. You make it complicated. The answer is easy. His serum albumin 16 gram. What's the risk of low albumin in this patient? Needs to be on something.
Mm.
Will you transplant him as well with
Thrombosis.
albumin 16 grams? The wound will never heal. His mass is proteinuric, nephrotic range, 7 grams per day. You need to switch off the tap and you need to correct this. Let me see magic answers. Anticoagulation, Mustafa, well done. Yes. Any patient with serum albumin below 20 should be anticoagulated. Because the risk of thrombosis, clotting factors, abnormalities here. Nephrectomy, how would you do it? Yes, nephrectomy, I agree with you, Rami. How would you do it? Medical nephrectomy, Mina, well done. Yes, you start medical nephrectomy. Of course, a nephrology colleague, well, you are a nephrologist. I've forgotten. Yes, stick him on dialysis, or give him non-steroidal, or give him cyclosporin, or give him ACE inhibitor. You need to damage this kidney to stop the proteinuria, and this will give time for albumin to improve. Also, you need to anticoagulate him. Surgical nephrectomy if medical nephrectomy fails. So please don't undermine the low albumin. You can't operate on a patient with low albumin. You can't send him to the surgeon because he will fall into bits. So anticoagulation, increase thrombogenicity, and lead to low albumin, need bilateral nephrectomy, medical, surgical prior to transplantation. Thank you. Case 20. A 21 years old CKD5 patient in hemodialysis for 7 years. He has urine diversion in the childhood due to complex congenital abnormalities involving his urethra, urine diversion. Anyway, fine. He empties his bladder 5 times a day, daily with occasional UTI. He's not yet on dialysis. The eGFR is 14. Received kidney offer from a deceased donor, full house match, no DSA. Photograph is shown below. What do you think about this urine diversion? What do you call it? And what are the key points to consider in his transplantation? Magic answer. Mitrofanov. Well done, Nisreen. Yes. To consider, basically, you may not be able to answer this question. Oh, to be honest, I put the ureter into his bladder. And also, I asked him to catheterize himself before he went to sleep, because he's the only one who can negotiate the catheter into his Mitrofanov. Mitrofanov, it is an appendix draining the bladder. This is what we need to know from this case. What I have hidden here under his trouser, full of scars. So it was not a straightforward operation. Case 21, 45 years old Asian lady received kidney transplant 7 years ago, full house match, no DSA, her primary function reported unknown, no history of passing stone, ultrasound scan 5 years ago, reported bilateral small kidneys was multiple stones, no comment on nephrocalcinosis. And this is one of our disasters. A family history of a brother, we came to know this later on because she, as you mentioned here, Asian lady does not speak English. Very poor historian. A family history of a brother who is on hemodialysis in his home country, but the etiology is also unknown. Kidney biopsy 1 hour after the perfusion was comparable with ATN, primary non-function and dialysis dependent. Biopsy 1 week later was reported as ATN, was oxalate in the tubules. We did the CT scan. What did we transplant here? Was a primary disease, which we couldn't diagnose prior to transplantation. Primary oxalosis, type 1 primary oxalosis. Needs liver transplant, yes.
PR.
Yeah. We couldn't take proper history because of the language barrier. In spite of all attempts, in spite of all discussion, we missed primary oxalosis, transplanted. Even the ultrasound scan was misleading, showed just few stones. It didn't report any nephrocalcinosis. When we saw the biopsy, we CT scanned her, we found very impressive nephrocalcinosis. When I looked at the primary oxalosis transplanted without even any intervention or treatment, 15% diagnosed post-transplant. So it looks like some of the cases can slip through the net. Fine. Okay. Yeah. Just this is a diagnosis. What another question? What's the commonest cause of death in this condition? Primary oxalosis. What's the commonest cause of death of these patients? CVS, cardiovascular disease. Yeah. Infections is second cause. Yeah. Cardiac, yes. Especially arrhythmias, because calcium oxalate precipitates as well in the heart, causing conduction problems. Well done. Yeah. At 24 years old, CKD5 main presented to you with eGFR 14 mils per minute. He's not yet on hemodialysis, but is keen to have kidney transplantation. His sister, who is 101 mismatch, wants to donate. No GCA. His primary disease was primary oxalosis type 2. How would you manage this case? Oh, I didn't, by mistake, I didn't remove his name. Apology for this. Is he transplantable? Alhamdulillah. Gali, yes. Is it kidney and liver? The answer is no, kidney only. Type 2 is different from type 1. Liver transplantation is not indicated in type 2. And the cause of primary oxalosis type 2 is different from type 1. It's multiple enzymes which are low outside the liver as well. So liver transplant won't help. And the outcome is variable for these patients. So I counsel these patients basically and inform them that, transplantation outcome is variable in his condition. It may work, it may not work. Preoperatively, he had intensive dialysis every day to clear up his oxalate. Everyday dialysis. Then transplanted, and transplantation is successful. But type 2, it can be transplanted without liver, but the outcome is variable. 23, you were offered kidney from a 54 years old female deceased donor, cadaveric donor, who suffer from subarachnoid hemorrhage. According to GP notes, the donor has mild diet-controlled diabetes, no proteinuria, no history of hypertension. The baseline serum creatinine was 86 micromole per liter and 78 on 2 occasions before retrieval. And excellent kidney function. The kidneys are shown below. Also kidneys, yes, straightforward. Answer, how would you transplant these kidneys? Transplant both together, upside down. And what are the problems with these kidneys? I used to worry much when I get them. Fine. Okay, because this comes in cadaveric, never happens in living, because you won't take kidney from a living donor with also kidney. Is it right? I will give you the answer. Basically, we divide the kidney here using a vascular stapler, but the risk is to make sure that there is no communication between both kidneys in terms of the excretory system. So we inject methylene blue into the ureter to make sure that it's not leaking from the cut here. Alternatively, in Liverpool, they inject propofol. It is an anesthetic drug, is like white, like milk. So a colored fluid, at least you can make sure that it's not leaking. You make sure that the urinary system both are not connected together. It is just fibrous tissue band here. The second worry is these kidneys usually have multiple arteries, so the higher risk of vascular complications. Luckily enough, this kidney, each one with single artery, transplanted into 2 different recipients. But retrieval, they should retrieve it in block and offer to one center. And this is the answer. Well, nearly there, nearly finished. A 45 years old renal transplant recipient, which is excellent kidney function, referred to clinic with weight loss, lethargy, easy fatigability. He's on CNI-based immunosuppression since his transplant 9 months ago. Clinically, there's an enlarged axillary lymph node bilaterally, no other lymphadenopathy detected elsewhere. CT's chest demonstrated bilateral axillary lymphadenopathy, thick white arrows, and also thymic shadow. So night sweat, night fever, easily tired, lethargy, 9 months, transplanted 9 months ago, and axillary lymphadenopathy. How would you manage? What's your differential diagnosis? Lymphoma. Saja, we shouldn't say lymphoma, we should PTLD. Yeah, EPV serology. Shift. Actually, the diagnosis is incomplete. Are you happy with CT chest? No. What's your answer then? How can I make you happy if in a cytology? My colleagues, you need CT chest, abdomen, and pelvis. CT chest, abdomen, and pelvis. You need to exclude infection first. PET scan, yes, okay, but CT chest, abdomen, and pelvis. And this is a typical picture of PTLD. It didn't come to the mind of the registrar that PTLD, this is why he CT scanned the chest, but CT, chest, abdomen, and pelvis. Fine. Move on. At 25, case 25, you were offered a kidney from a 59 years old DVD donor after brainstem death who suffered subarachnoid hemorrhage complicating cerebral aneurysm. His retrieval creatinine was 72. Virology reported as follows: hepatitis surface antigen negative, hepatitis surface antibody negative, hepatitis core antibody positive. Both hepatitis E antigen and E antibody are negative. Both hepatitis C and HIV are negative. This is a cadaveric donor. Will you accept this kidney? I need justification for yes and no. No high risk Mina. Mustaba, yes. Mina Mishirki. Sabah, yes. Why yes, why no? Natural immune, Muhammad al-Shahad, well done. Yes, serology. Okay. No, Mustafa, serology, if he's immune due to vaccination, he will have hepatitis surface
Surface
antibody
antibody.
positive. But I agree, this is an immune due to past infection. Even I won't bother to have PCR. This will be in the middle of the night. Let us review together. Hepatitis surface antigen. This is hepatitis B immunology or serology. Surface antigen. This is acute infection or chronic active hepatitis. Hepatitis surface antibody means immunity. Hepatitis core antigen. This is actually in the liver. So you need to detect it by biopsy. We don't look for it. Hepatitis core antibody, IgG or IgM. If it's IgG, I'll tell them no, thank you, because this is acute or recent infection and usually associated with DNA. PCR will be positive. IgG means previous infection and usually associated with hepatitis surface antibody. But the problem with hepatitis surface antibody, it comes down with time, tend to disappear. So this guy, if it's IgG, I will take it. If it's IgM, I will say no. And usual IgM associated with hepatitis surface antigen positive, and you find DNA as well, which is the virus. To complete the picture, hepatitis E antigen usually associated with high level of hepatitis B virus, so the PCR will be positive. Even the E antibodies is low infectivity, still effective. So we need to know the hepatitis B serology to make a diagnosis. This is a very common scenario in our practice here. This is the last case. Thank you for your patience. 61 years old, CKD 5 secondary diabetic nephropathy, had a deceased donor transplantation, cadaveric donor transplantation currently. She is on tacrolimus-based triple immunosuppression. Her kidney function has improved and started to pass urine. On day 11, she developed dry cough, low grade temperature, 37.8. Clinically, there was few scattered physical signs, few crips. Respiratory rate was 21, was just rapid, but not that fast. Sputum, culture sensitivity were awaited. What comes to your mind, given this picture, and what would you do next? PCP, Muhammad Shahad. PCP. What's SMX? Sputum.
Sulfur.
Yeah, okay. Sulfonamide. Yeah. Could it be CMV? Or could be routine chest infection? Be high. Of course, you need to exclude. I agree with PCP because this is a case of PCP, definitely. But CMV can give a similar picture. Yeah, so we have to exclude bacterial infection, viral infection. So
fungal
infection, every known infection. But again, the CMV and the PCP, and this is actually the chest X-ray, so bilateral perihilar infiltrate. Fine, let me show you the CT scan. CT scan is worrying. So ground glass appearance. So a good pneumonia Yeah. What you need to do, differential diagnosis, we mentioned differential diagnosis here. Also, you need to do blood gas. Why we need to do bronchoalveolar lavage? Why bronchoalveolar lavage? Why not to diagnose the PCP from sputum? Programstin, hypoxia. Yes. Number one, yeah, I need to answer. Because the sputum usually very thick. And this is why we need bronchoalveolar lavage. Usually the blood gas, gives a picture of desaturation, low oxygen level with PCB and also CMB. Sensitivity to bronchoalveolar lavage is more than 90%. Well done, yes. Fine. Treatment. How would you treat? This patient, to make life complicated, is allergic to sulfonamides. Dapsone, yes, excellent. Pentamidine, Ahmed Abdullah, excellent. Pentamidine, stop antiproliferative. Yes, this is one of the treatments, yes. Stop MMF, yes. No, he's allergic to sulfonamide, I'm afraid. You cannot give cotrimoxazole, pentamidine. Cipro, this is third line. Pentamidine. How would you give pentamidine, Muhammad Saftawi? Oh, pentamidine. Inhalation, yes. Yeah, that's right. Yeah, it's inhalation. Pentamidine is not available. Well, some of the colleagues mentioned Dapsone here. Yes. So, Cipro as well, ciprofloxacin. Yeah. So the key point is bronchoalveolar lavage is indicated if you suspect PCP. Why? Because the sputum is thick. You need to get it out of the bronchi. Number one. Number two, the physical signs do not match the radiological picture at all. Blood gas is indicated. Sulfonamide treatment is the first line of treatment, therapeutic, not the prophylactic dose, big dose. Patient allergic to sulfonamide, think of Dapsone or pentamidine if it's available. Pentamidine is taken as inhalation once a month in a room, special room with a negative pressure. So Dapsone will be easier. Thank you very much. I think we you finished today.
Thank you very much, Professor Ahmed, for this.
And
for this very, very elegant and the huge effort you have done, and I think it also reflects the vast experience in managing kidney transplant patients, not only from the surgical aspect, from all aspects actually as well. But I would like at the end to summarize or to give a harvest of some important points or messages or lessons that we have learned from this webinar. I think antibody-mediated rejection, the first line of treatment, we agree that it's IVIG and plasma exchange. This is the first line, it's the standard practice. C4D negative antibody-mediated rejection carries the bad prognosis. For TMA or HES, it could be a feature of antibody-mediated rejection, so we have to do DSA and C4D staining for these cases. For cases with gingival hyperplasia, it's not only cyclosporin, we should look for other drugs like calcium channel blockers and phenytoins. DSA against DQ, especially with low MFI, could not be considered as a high-risk patient. Breast is not always posterior and it is not always reversible. Pyelonephritis could be diagnosed by graft biopsy in absence of evident UTI. Osteonecrosis or avascular bone necrosis can affect any joint. MRI is the gold standard imaging for diagnosis. Sirolimus is one of the risk factors, especially for premature avascular necrosis. Non-HLA antibodies is a common cause of positive cross-match with negative DSA, and the prognosis is not favorable. For perigraft collections, not all collections need interference, only in certain conditions, depending on the site, size, and mechanical effects, either on the vascular or the urinary system, or of course the presence of infection. Any infected perigraft collection should be drained. CT scan should be urgently carried out to rule out the possibility of retroperitoneal hematoma when hemorrhage is suspected. Ultrasound is not enough. For polycystic kidney, not all polycystic kidneys need to be removed prior to transplantation unless huge or the cysts are complicated. And if indicated, we should consider unilateral nephrectomy in order to preserve residual kidney function and endocrine function of the kidney. History taking is very crucial from the transplant candidate, and it could provide an important clue for the original kidney disease. And liver transplant is not indicated in type 2 oxalosis, and outcome is variable. These are some of the messages and lessons that I think we have got tonight from your wonderful presentation. I do appreciate your kind efforts in supporting our meetings, and especially in transplantation. I hope and I think everyone enjoyed the this webinar. Thank you very much, Professor Ahmed.
Thank you very much, Professor Ayman, for this comment. Actually, this is much better than my talk.
No,
Your summary is better. You made it so easy.
thank you, Professor.
Yeah,
Thank you
yeah.
very much.
In addition to, if you suspect renal vein thrombosis based
Yes.
on the duplex, go for a CT scan, go for another modality, because it could be still perfused kidney. And what you need is just to, unkink it. It could be kink of the renal artery. And it happens many occasions. This is why we don't rely on ultrasound scan. We book contrast CT scan. We don't worry about the contrast nephropathy here, because we have a kidney is going to fail. And book at the same time for surgical intervention when needed. You need to read the duplex very well. It's not that difficult, few bits and pieces. Focus on the resistive index, make sure that within normal. If it's higher, think of renal vein thrombosis or other factors like ATN. It could be medical reasons of increased resistive index. Reverse diastolic flow almost always in the renal artery. Could be renal vein thrombosis, could be in ATN, could be even the recurrence of the primary disease.
Yes.
It's just reflection of unhappy kidney. And thank you very much, Professor Ayman, for this comment.
you very
And
much.
thank you very much for this opportunity to give this talk. And I hope this makes difference for your practice.
Of course it is. Of course, Dr. Ahmed. Thank you for the audience and the great answers. And I think we have experts. And I think this is the harvest of your education, Professor Ahmed. I know that most of the audience are, the majority are your students, and I think they are getting a lot of benefits from you and from your courses and the fellowships. Thank you very much
Oh,
for
thank you very much.
for
Yeah.
your efforts.
Okay.